Well, welcome. Today we're going to talk about digital dentures, 4 clinical workflows, manufacturing methods, and implant dentures. But first, please meet my family. So in this picture, I have 5 kids, but just recently we had another addition. She's only 2 months old. I'll tell you like this, English is my second language, so some people might hate my accent, some people say they like it. I'm not sure if they're just trying to be nice. But anyway, and another thing, I'm not a professional speaker. I do consult many dental professionals, especially nowadays on digital dentures, taking impressions. Why do we talk about digital dentures? Well, reason number one, they're here to stay. Our conventional department or non-digital analog department, manager over there, he goes to me, oh, digital is not ready and let's just make sure we concentrate on conventional department more than on digital. But even he, in the last year, he came to me and goes, you know, I cannot get this material, I cannot get base plate material any longer. So majority of the conventional materials, they start going away. The market moving towards digital. And some of the materials for conventional way of making dentures, we have hard time finding them. Companies moving to digitals. Second reason, they are more precise. I had one of my other friend, he's also a general dentist, and so he was making dentures for his daughter, unfortunately for his daughter, over 4 upper implants and 4 lower implants. He came to me and said, well, can we both work on this case? And he asked the suggestion, what do you suggest? A digital over denture, or we made for her, which is called the clip-on removable bridges, or the conventional way? Well, I said, I would prefer digital, but let's do that. We'll do a conventional for her, that clip-on bridge, and a digital. And at the end, whatever you guys choose, that's what we're gonna go with. And at the end, they're choosing digital clip-on bridges for her. Why? Because they looked better, they fit better. And there are a lot more available options on the digital dentures. Even full denture. If you will stop by our booth over there, you will see that there's some dentures that have a zirconia teeth into the acrylic base. You can choose from variety different materials. Right now, the options are just enormous. When we have in our conventional lab, we would have like some maybe Ivoclar teeth, some bioform teeth, maybe some condylar teeth, depends on the quality. When it comes to a digital design in dentures, you have all different types of molds right there. For economy denture, you can actually choose the signature type of a design teeth. They really reduce the chairside time for you. When we'll come to the manufacturing process, when we make a best denture using maybe Ivoclar, injecting the acrylic, there's still enough of a shrinkage to the material. It's a 5% shrinkage. That's why you have to do a palatal seal. On a digital dentures, you don't have to have a palatal seal because there is no shrinkage at all. It's very precise. A dentist called me and said, you know, this patient really loved her teeth and she wanted a second set of teeth. But she have to fly away because she came from Chicago. Can we make a copy denture within a day? Yes. All the files are there. All the impressions is already in a computer. But she was thinking on a new set, can the upper teeth would be just a millimeter longer because she's not sure, does she want it a millimeter longer or not? So on the second set, she would prefer that. Very easy. Just go back to the file, brought all the teeth down, and mill those dentures. She got pretty much the second set of dentures within a day. But mastering digital dentures requires some commitment. I remember when we started, at first we got really discouraged. We actually started 13 years ago. There was a company called Sensible Technology. It was the first company who started making the digital partials. We had those haptic devices that when you design, you can feel virtually the undercuts, the grooves of patient tissue, of patient teeth, and that's how we would do the wax up. So we were their beta lab, and of course invested a lot of money into it because at that time the printers, they were much bigger, much more expensive. The regular printer would cost you almost $200,000. The design station would cost you about $25,000, but we decided to invest into it. And over time, of course, we were constantly comparing because we would still have a larger portion of an analog way of doing things. And I had some technicians who were the master technicians working in my lab who only would do by hand. And at the end, actually, they started doing digital as well. The only reason we invested into the digital equipment, not just because we want to make it faster or where it can produce to us more money, even though in the long run it did that. But to me it was, how can we be more consistent? When I have some technicians in the lab that has a way of making a little bit thicker partial and the other technician like to make a thinner partial, doctors don't like that. How can we be more consistent when it comes to thickness? Or if a certain doctor, he likes his partials and dentures to be much thinner, more elegant, how can we put this into the system that this doctor likes always his partials to be thinner, the clasp has to be thinner? With digital designing, you put that information and it automatically does that for this type of a client or a doctor. Yeah, in our journey, there was a time, of course, we got discouraged as well. So we got good printers, everything worked out in a lab. When we went to clinic, all of a sudden, this denture just doesn't fit well. The palate is not snag over the patient palate. Over time, we had to find out what kind of equipments will work for us. But there were some printers that were more expensive, but when it comes to quality, the quality was not there. And our other providers, they got discouraged. Digital denture doesn't work well, or the color is not the same. So there was some growth pain. But before we talk about why digital dentures work better, I do want to talk about the 4 clinical workflows for your office. One of these clinical workflow should work for you right now. You don't have to change anything. You even don't have to have an oral scanner in order to start getting digital dentures, and that's what I'm here to talk about. Whatever you already do in your office, you can do same thing actually, and you can get digital dentures because all this information, even from analog information, it can be converted into digital, and we design digitally. So first, we're going to just talk about this basic conventional impression workflow. If a doctor doesn't have oral scanner or he doesn't want to use oral scanner and still want to go through all the same steps as he make in a regular denture or partial, can it be made digitally? Can all this information be stored digitally? So if a patient lost their denture, it can be reprinted or remilled in a day? Yes, it can. And let's talk about this basic. You know those steps, and that's why I want to talk about something that you already know. So when we talk about digital dentures, they don't scare you, but you think, well, nothing changes in my office. Actually, it's whatever the lab has to do, maybe change slightly. So basic conventional impression workflow. Take an impression. I mean, there could be many reasons why sometimes they want to switch to a different impression. There is many other good system, good impressions, but briefly, I'm going to talk about what's really been working for many practitioners when we suggest to them certain material. This is one of the impressions just recently was taken in our clinic. So for edentulous patients, Massad trays, Dr. Massad trays working really well. Why? You can grab your torch, you can heat up those flanges, you can extend the way you want it, you can modify them, and then where you think the size is right, they also come in different sizes, but when you even want to customize, very easy, very quick, and then apply this extra advanced facet heavy body material only over the flanges and in the back palate. It will give you a custom tray practically, but I'm going to show you an example what we want to do. So we applied it right here on the flanges and just in the back palate, and want to make sure that we have this free space, so when we're going to apply the second layer, the material can escape down. If you're not going to have enough space to material to escape down, then a lot of times what happens when you start putting the tray again in the patient mouth, the tray already not in the same position. You don't get this nice flanges. So you want to make sure that when you're applying first heavy body layer, it only goes in the flanges and in the back palate. Then you apply next layer, it's either extra light body or just a light body. It gives you perfect impression. So you get a final impression in the first visit. There is no reason to go through all those custom trays. Even in a lab, when they make you a custom tray, sometimes the flanges is overextended. So this Massad tray, the flanges are never overextended. You build up those flanges with the heavy body impression that you already probably have in your office. We give you a suggestion. We're not part of those companies. They don't know that we're promoting them. We're just showing you what's really working actually. So then second appointment, we're talking about digital denture. Here we're going to establish the vertical dimension and centric relationship. I'm going to also give you a few tips. I go to some other dental offices because they would call me and said, well, one of your technicians made those dentures and they're too big. Can you help me? So I come to their office and I see the dentures are too big. Well, I know the technician cannot make bigger dentures than what they've established when it comes to the wax rim. So I said, well, in this case, we have to remake those dentures. They're too big. There's nothing we can do, like start over from bite trim. So when a lab makes a bite trim, an upper bite trim by the book, gotta be 22 millimeter, lower 18 millimeter. The doctor placed those bite trims into the patient mouth and he started taking a blue mousse bite. And I'm like, just wait just a moment because the dentures are gonna be too big. Yeah, but they made the bite trims too big. They're gonna come all the same size. It's your job to trim them and make sure you trim them well. And especially on a digital dentures, I strongly encourage to spend some time right here, to give some pictures, to do some markings, and we're going to talk about, because on digital dentures, sometimes you even don't need a trine. You can go right away to a process. And that's what many labs do right now. They would actually require the doctor provide them pictures, provide them good markings, and then go into the process right away. We still kind of encourage you to do a trine just because it's better to try and see and not to have a remake. But you can provide enough information where a lot of times, 90%, it's always can go into the process. So let's talk about those few tips. Tip number one, you want to modify your lower wax rim. You always want to do that. You do the cutout right here from the interior portion. Why you want to do that? Because each time when you're going to ask patient to go ahead, close down, they thinking bite down. When we bite on a food, at this instant, a patient gonna bite on a food. What they gonna do? They're gonna move their jaw forward like they biting on a food. When you take away that front portion, they know they have almost like what they think no teeth there, so they cannot bite down. That's when they start closing down. But when we close down, then our jaw is relaxed and it's in a centric position. So when they even see that there is no front portion, there is nothing to bite on it, they close instead of biting. Second tip is that you want to do cutout from the most posterior portion of a base plate. Why? Because a lot of times when patient actually bite down, you don't see it, that maybe the posterior portion hits first. It slides the tray a little bit forward and comes into the bite, you think, but it's not positioned in gums properly. So you want to do the cutout over there as well. And then before you take in a bite, you tell patient that you're not biting down. You're only closing on this posterior portion of a teeth, and that's it. That's when their jaw relax and they close down. And they will give you a perfect bite. A lot of times patients don't know where their bite is. If their denture are severely worn out, then what happens is that they don't know where their true bite is. It's going to be your job to place them in the proper position, actually. Otherwise, what's going to happen? You're going to go through the trying, and when you're going to go even in a process, in a first appointment, they will come to you, and they're going to move their jaw slightly forward. A couple of weeks later, they come back to you, and there is a big gap because now their actual jaw went back. They have a taller teeth, and finally their jaw relaxes. What you have to do, it's a remake at least of a lower denture. Yes?
But I used a barbaric tracing from Swiss.
Yeah.
Tracing
Gothic tracing.
Yeah.
Gothic tracing. It's really good. When I had internship with Dr. Johnson over there in Portland, every case that we did in Gothic art tracing in a phaseball. But when it comes to phaseball, I saw hundreds and hundreds of times when the lab articulates, they just take that phaseball out. It started moving, they don't know. So we did that. The only reason we did a phaseball because we were measuring angle of each condyle, and then we would set it accordingly. But again, the special cases, doctors don't have a time for it. Gothic art tracing is actually good, but not too many dentists use right now. And so my job right now is to show how to take a proper bite. Because if you have enough experience, you will see and you will know that this patient is closing properly. To me, when I come to the lab and I see my technicians are setting teeth, and a lot of times when I see that even when they scan it or even an articulator, I see that the front cast slightly forward, pretty much I know the bite is incorrect. And I call the doctor and he goes, no, the bite, I know the patient gave that bite. I'm like, you'll see when the denture is going to be made 2 weeks later, patient going to move their jaw forward. So let's go ahead and on a bite trim right away find out where that proper bite is. So here I'm showing without Gothic art tracing. Very simple, but 95% of the time, it's going to give you a good bite. Because front portion, patient don't have actually front portion, they're not going to bite down, they're going to close down, their jaw goes back. Another trick you can ask patient when you put a blue mousse bite, you can ask them instead of a closing down, you swallow down. When they're going to swallow down, that's when the jaw goes back, and you swallow down and you hold it there. And that's it, they're going to give you a perfect bite. But in order to do that, you want to trim this well enough, and there's going to be one more step to it. So here's the markings that we require, especially for digital dentures. On digital dentures, it's important. On conventional denture, why sometimes this information can get lost very easily? Because when it comes to the lab, the technician gotta set teeth. What most likely he's gonna do, he's gonna cut this front portion of a wax because he doesn't have enough time to cut for each tooth. He's gonna cut right away, and some of this information lost right away. On a digital, as soon as you scan this marking is always there. So he's not setting teeth into the wax. he always see those markings, and when he said those teeth, it's a good reference point from him for the technician always. Well, let's go back one more step here. So canine position, midline, lip support, extremely important, and patient pictures. Patient pictures, you just place those wax rims in, you have a retract tools, and take a picture. Digitally, what they're able to do, they can articulate that picture, and now they can see the position. Even they will see if you mark the midline not in a proper position, then they can go ahead and adjust that. And if you spend time right here, then a lot of times digital dentures, they're gonna go great. So next step, before you take a Blue Moose bite registration, you wanna warm a lower bite trim in a hot water so the wax becomes soft. What happens for you, it's almost impossible to trim both sides in exactly height that patient need. And what happens a lot of times, when patient bites on one side and one side hits first, you don't see that, but what patient do, they will slide their jaw into the bite because they think we gotta be in a bite. So each time they're gonna slide into the bite. You take a bite, they set the teeth, it's incorrect. So when you're gonna warm up a lower wax that it's soft, you place in a patient mouth and you ask patient gently close down. It's gonna press wax just a little bit, and now patient actually occluding on both sides evenly. That's when you take a Blue Moose bite. Yes, go ahead. Yeah, taking a bite with wax, what happens is that when you start separating, it starts elongating that wax a little bit. And if you feel confident that the wax is hard enough, but a lot of times when patient bite down, there could be a situation they just barely bit down that you don't want them to bite too much into the wax where it gives that good puzzle. So that's why I would still suggest to use a Blue Moose bite. But there is a situation sometimes you ask patient to bite harder, much harder, that's when their jaw goes forward actually. So you want to be careful, make sure patient is not biting too much into the wax. That's when they feel like they start really biting and moving their jaw forward. So it's got to be very gentle where they can press down onto the wax and you see, okay, they're in a good position, and then you take a blue bite registration. But I mean, you can use some other techniques as long as you feel confident and you have a system and you feel like this information can be transferred very well to the lab. Because the most important, okay, when a lab got a bite from you, are they able to articulate properly? Or when they start separating those upper and lower wax, they already distorted somewhat. And when they place it back in, it's not in the position it should be. But you can use not just a Blue Moose, whatever works for you, as long as you get a good bite. So trine. When a trine comes to you, that's when doctors who did not do digital dentures, they're confused what to do with a trine. So if you did a trine and the teeth needs to be moved somewhere, there is 3 ways how you can do some modification. Number 1, by description. You can just write on a lap slip, okay, move the midline, move the teeth forward, down, and send back to the lap slip, or scan it, send back to them, they can do the changes. Or if you don't want to write, you can just do the markings. They also can scan this information and follow those markings. That's number 2. Number 3, it's cutting back the trine. The trine will not be part of the original final denture or the final product. The trine, right after the trine, it all goes into the garbage actually. You can do whatever you want it, you can trim it. If you do the trine and patient's bite is slightly off, you never just retake a new bite. Because if you take a new bite, a Blue Moose bite right away, you open in patient at least by 2 millimeters. Because the cusps are not in a puzzle right now. So right now it's a cusp on cusp, and you open in patient automatically by 2 millimeters. That's on conventional dentures. On digital dentures, it's given. So you want to actually take your burr and cut the posterior teeth at least 2 millimeters to a central groove. Or if you feel like you want to close patient down even more, that's when you start cutting those posterior teeth on a lower trine as much where you feel like patient is in a vertical dimension and centric relationship where you want them to be. So you can cut this trine as much as you want it. Then you take a blue moose bite registration. When it goes back to the lab, they rescan a new bite, and the teeth will be set to the new bite. So that's a third way of doing it. And when a bite is off, you always do a cut back. You cannot just tell a lab to go ahead and bring my bite down by 2 millimeters. If they do virtually, there are always going to be some adjustments. And fourth appointment is delivery. So we're talking about digital dentures, but I want to show there is not too much changes when it comes to a clinical workflow. It's mainly what's done in a lab. It's very basic, very simple. The only difference, it's actually the trine. So next workflow, it's using your digital scanner for a workflow. Number one asked question is that which gives you a better impression, a digital impression or conventional impression? Depends what kind of product. If you do a removable partial, an oral scanner will always give you a better impression than the conventional impression. That's just because of some shrinkage going on. That's when you put in the model, and we tested many, many times. Those doctors who send us digital impressions for their partials, they would always tell me the partials fit so great. And so I would recommend, if you have an oral scanner for partials and some other appliances, use the oral scanner if you can. For full dentures, well, it's very hard to take impression on a soft tissue. I saw some impressions that some offices did was great, but majority has a trouble to extend the palate as much as we need, or where the retromolar pads and hemolar notch and upper or lower, they have hard time to capturing that. So, but that will really affect the denture. So some advantages of conventional impression for full denture, even though you use conventional denture, but we're gonna do the digital denture. It's of course when we're able to extend the vestibule as much as we need, that's what gives you the great retention. So another advantage is that it provides a compressed tissue impression. Well, some actually saying that it's a disadvantage for a denture. There is a debate. But when you take a conventional impression, of course, the tissue is under the load. And like I said, some say it will give you better retention, but not necessarily, because there is a debate about it. And a better palatal extension when it comes to conventional impression. On a digital impression, it saves you money. Can you imagine you don't have to buy all these impressions, all those trays, even when I talked about Dr. Massa trays and all that stuff? It will save you money. Instant delivery. Right now we have more than 50% of our doctors and clients, they're out of state. And out of state, it's even more convenient to have a local lab. Why is that so? Because when it's a local lab, the driver always running late. I mean, that's just given, yeah? It's a traffic, it's this and that. When it's out of state, it's gotta be a day before in their office. So you know it's always there. But in digital impression, you took the impression, you sent to the lab, they can start work on case right away pretty much. So instant delivery and relaxed tissue impression. So I've talked to many doctors who did a study on compressed versus the relaxed tissue, and some claim, even though on digital impression, you cannot get the vestibule extension, but because it gives you relaxed tissue impression, it actually gives you better retention, and therefore in the end result, both dentures fit about the same. But again, that's for you to decide. Right now, when we actually got many cases for full denture on a digital dentures, we still get more of a conventional impression, and then we scan it and convert. Okay, difficulties. It's vestibular borders, palatal extension, and hemular notch extension. That's very difficult to get, especially if a patient have a big undercut, then it's almost impossible to take an impression there. That's where maybe you will need to do a conventional impression, or we're gonna talk about the next workflow. It's called the triple tray workflow. That's where if you got a bad impression, either conventional impression or digital impression, sometimes you're gonna decide, you know, I'm not gonna retake the impression. I'm gonna send for bite trims, and I'm gonna do something later about it. And that's gonna be another workflow. But in here, even though you have the oral scanner, when it comes to full dentures, all other steps is exactly the same. Nothing changes. So the only difference is either you do conventional impression or you do digital impression. So here's a triple tray workflow. That's actually a workflow that will make dentures fit great. It will give you a very nice bite, but it does take and requires a little bit more time. When and why to use a triple tray workflow? Number one is when your impression is bad. It's either digital impression or conventional impression is bad, and you're like, I'm not gonna retake the impression, I'm gonna deal with it later.
Question on the
Yeah.
triple tray. You don't border mold?
You don't what?
Border mold?
On the triple tray,
Yeah.
you do border mold on the next step actually.
Gotcha, okay.
Yeah, so that's why, and that's another reason right here. On triple tray impression gives you a functional impression, because that's when you can do a border molding, that's when you can ask patient to go ahead and do the work through their muscles, and it will give you a functional impression. So the impression under the function. And so on the first step for a triple tray workflow, you either take a conventional impression or you take a digital impression. The impression was not that great, you know right away, but you send to the lab so they can provide you a bite trims. When they provide you a bite trims, you go through all those steps where you do the marking, where you establish vertical dimension centric relationship, you establish all of that before you take a blue mousse bite. That's when you take, we can say, just a reline impression in upper jaw. Make sure the lower bite trim in the patient mouth. So when you take the impression, you ask patient to bite down, then you ask patient to actually work through their muscles. You do the border molding, so it gives you functional impression. Then you do same thing to a lower base plate. Also, you take the impression. If you need another layer, at that time you take a light body material, you apply the second layer, especially in the lower. A lot of times it's nice to have a medium body and then go ahead apply the second layer of a light body. For some reason, it will always give you a better fitted lower denture. And so now we got almost like a reline impression, upper lower impression, and that's when you take a blue mousse or blue bite registration. Now, when all this information goes back to the lab even doesn't have to separate the triple tray. They just put on their desktop scanner, it scans the upper, lower, scans the bite. That's it, perfect. Nothing was removed, the bite will be perfect. Then, same thing, going through the trying and delivery. But let's talk about using existing denture for a workflow. Well, when you can do that, when patients do have an existing dentures. And even if a bite is off, you still can use this workflow to give the patient, possibly they will say, the best replacement dentures they ever had. What are the advantages of this workflow. Number one, it will save you money. In this workflow, you probably will only need 2 appointments and give the best possible denture for a patient. So some advantages. One advantage, it's only required 2. Sometimes some doctors want to still do a try-in. You can go in a 3rd appointment. But patients who are accustomed to wearing their dentures will quickly adjust to this new denture. They like their old denture. So that's why you would actually pretty much copy and improve on their existing denture. That's when you do the improvement as well. I'm gonna go over taking impression. So you take a practical reline impression. You cannot grind on this existing denture. Well, why? Because patients still wearing their denture. And most likely, if you take an impression, they want this denture back right away. But anyway, you take an upper impression, like a reline impression. You can also make it functional. Let the patient work through their muscles, and you take a lower impression, then you take a blue bite registration. Now you have a nice triple tray impression. But plus to that, the technician have some reference points where the old teeth were. Now they can improve on it. Let's say you want the teeth to be 1 millimeter longer. That's when you write this description. But what about if the dentures are too worn out and you want to open them vertical a little bit? Well, you can actually place a wax on the posterior teeth, and when patient gonna close down, their bite is open by 2 or 3 millimeters, whatever it's desired, and that's when you take a blue bite registration. Now you've opened patient slightly, it's nice and easy, goes back to the lab. A lot of doctors, for some reason, they would actually give us impression and then they would say, open a bite by 3 millimeters. We can do that virtually, but it's never gonna be correct. Each patient have a different jaw movement. The computer or even articulator, they just see that patient have a 30-degree perfect jaw movement, but no patient have that. So that's why you want to open patient in an office. So when the lab scan this information, they scan in a position where they have to be exactly in a centric position. So then what happens, next step, you scan this impression. You can use your oral scanner to scan this impression. You scan upper impression, lower impression, scan the bite. But it's difficult. You have to have a lot of practice in order to do that. Those who have a good ability to do that, just use your oral scanner. But there is many doctors to call us and ask, what do you suggest to make my job easier? And I suggest that they buy a desktop scanner, a basic desktop scanner. In a lab and even in the clinics, we have different scanners. We have a 3-shape scanners, desktop scanners that cost close to $30,000. You don't have to spend that much money. You can buy one scanner, I'll tell you, it's called a Shining 3D scanner. It is made by China, but the headquarters here in San Francisco. We tried the scanner. It works perfectly, especially for dentures. But the price between $6,000 to $10,000. When you want to scan something for full dentures or even dentures and partials, if you have desktop scanner, it will make your job so much easier. And we had a lot of doctors also, those who do a lot of dentures, they bought those scanners. So when they take either the triple tray impression, they take the impression inside of a patient dentures, right away they just scan it. You place this impression on top of a scanner, it scans it for you. Then you place the bottom side, it scans it for you. You can send to the lab. Why the Shining 3D? I'm not part of them. I'm just telling you what's really working. Works well. You scan upper impression, you scan lower impression. You cannot put them into the bite. You send everything to the lab, they able to put everything into the bite. It saves you so much time. Their software and their scanner does a great job for full dentures. So now when all this information comes to the lab, green, that's pretty much what comes to the lab. So they have a reference points where their patient old denture teeth were. So now if you want a technician to set the teeth a little bit longer, just write on the description, and they will use their old denture as a reference points to set the teeth. After that, you can either do the trying if you're not sure, or you can go into the process. A lot of times when dentists go into the process, they would tell me this denture fits great. Another suggestion, I'm not sure why, but every time I see that when patients get dentures, the dentures are too big for patient mouth. If you want an upper denture to be aesthetically pleasing, then make lower denture to be a little bit shallow, a little bit lower. It will make a lower denture more stable. It will give more space for food, and patient will love it a lot more. On dentures, it's better to even close them a little bit more than if they would have natural teeth, then make the dentures to be a little bit bigger, because patient will, a lot of patients, unless they're young, they will not get used to it and they will not wear the lower denture. Especially if lower denture, the teeth are too tall, they just have hard time chewing with them. It's always better to make a lower denture to be a little bit more shallower and almost overclose them. So what happens a lot of times when a dentist do the measurements, they're not placing patient in a centric position. They actually just placing patient in a vertical position when they're in a relaxed state. But when we're in a relaxed state, there is a clearance between our upper and lower teeth. So a lot of times when they do the measurement, that's the information they provide to the lab, and that's how the denture always comes up to be just a little bit larger than what patient wanted. So immediate dentures. I don't know why those who made this PowerPoint for me, I guess he chose this picture. Anyway, let's talk about immediate dentures and the big advantages of using oral scanner for immediate dentures. That's where it's going to save you a lot of time and a lot of frustration. So on immediate denture, using oral scanner extremely convenient. Why? Because it will save you chair-side time. When patient come to you, you take a digital impression of an upper and lower jaw. Let's say patient only have couple teeth on each side, or some doctors even they do that. They would extract all of the teeth and would leave only one canine on upper jaw and lower jaw. Then what they're gonna do actually, they will scan this bite of just one tooth on each jaw. When they scan it, this bite, then what happens is that now the next step, when we able to articulate, maybe I don't have a picture, now virtually it's already articulated. So when you take in a digital impression for immediate dentures, we take upper lower impression, you take a bite, it goes into the process. There is no reason for bite trims, and it will save you a lot of time. There is another advantage to that. When we remove the teeth digitally, so here's the impression we got, and we were able to capture this great natural color impression from our screen. Then the next, digitally, we will remove those teeth. So on immediate dentures, pretty much always patient will have some of the pressure points on canine area, or maybe on posterior where a patient have more bony gums. So digitally, which conventionally we would not be able to do, we would apply some relief material right away where we know patient will have some difficulties or will have some pressure points. We would do a blackout undercuts as much as we wanted. Then when we print or mail you that denture, it just goes in. Where patient have swelling, it's already accommodated for that, it's already relieved. An immediate denture will fit so much better, and it will look better.
So also block out the tori?
Block out tori, block out everything, and that's why we teach our technicians, when you see tori, you do the blackout. Where you see the teeth were extracted, especially in canine area, And most likely that's where patient, when the denture gonna settle down, it's gonna create a pressure point there. You do some relief material there as well. So the technicians are taught to do that. So when it comes to you, and when denture settles down, it will just fit right. So when we say teeth conventionally, even patient did have their natural dentition, but what technicians a lot of times do? Well, they have to remove each tooth one by one and set a denture tooth. But most labs don't do that. They will grind all of the teeth. Right now they have no reference points. When you set teeth digitally, the reference point is always there. Why you can slide the teeth in and out, and you can constantly check for a reference points, and that's how you see that where the natural teeth were set. You also at the same time can see the morphology of a tooth, and you can start modifying that tooth into the proper shape. Plus, some doctors, what they do a lot of times, they would write to us, pretty much keep the same morphology, just improve the setting. And digitally, it's very easy to do that. I remember when we were teaching our technicians to do that using an analog setup, we would receive the cards and they would start grinding the cards and modifying them to those teeth, to make the immediate denture look great. There is a big advantage using the oral scanner for digital dentures. Why? You can take impression. You're practically always able to take a bite right away. And this denture practically always goes into the process as well.
So no impression with the material?
No impression with regular material, yeah, because if you don't have a scanner, you can use a conventional impression. But I'm showing in here that an oral scanner has so many advantages over the conventional impression for digital dentures. Plus, when you want some immediate dentures, a lot of offices right now use them to be only as the temporary dentures. Then when they do the permanent denture, what they do, they just take a reline impression and either they scan it or send to the lab. The lab upgrades the reline impression. And if a patient likes the teeth, the way they're set, sometimes doctor just gonna ask, just gingivally extend the tooth a little bit more and go ahead and remill a new denture. And we're gonna be a denture patient doesn't have to get used to completely new denture. In here, I'm trying to show as well how much digital denture will save you time and save you money and will get you a better denture as well. What's good about the scanning dentures for patients who are gaggers is that on digital denture, if the palate is a little bit shorter, we will get a better fitted denture. On conventional denture, the reason we need palatal seal is because there is a shrinkage happening to the material while it's polymerizing. And so to compensate for that shrinkage, you place the palatal seal. On a digital mill denture, there is no shrinkage at all. And so if the palate is shorter, the denture will fit better. But let's talk about the manufacturing process. So first, I want to talk about some of the problems on conventional dentures. Why conventional dentures? I believe they're not as good, even though we still do more conventional dentures in the lab, just because many dentists there still are not able to switch to digital. But I'll tell you some of the problems. Problem number one, before you inject the acrylic, you have to put a separator. In a lab, they always look at the consistency of that separator. A lot of times that separator becomes thick. So when they apply that separator, there's going to be a huge gap between the patient tissue and that denture. Technicians just got to do their job. They maybe invest in 100 cases at the same time. So that's why sometimes you always give them a good impression, but what happens, why this denture doesn't fit that great? There are many problems that can happen when you do the conventionally. Second, when you inject the acrylic, We do use some of the best equipments for the conventional dentures. We use the IVACAP, we use the Horace Colzer, but still when the material is polymerizing, what happens is that the material will shrink at least 3 to 5%. The best acrylic will shrink. For some patients, this will not be noticeable. For other patients, that's enough where they don't have the good retention. Another thing, when you start finishing that denture, the post-processing, when a technician starts grinding on this acrylic, some spots will be 3 millimeter thick, some spots in a denture will be 1 millimeter thick, especially those where the torics are, because it's very hard to keep that consistency. I don't know if you guys been in a lab and when you see the technicians finishing 20 dentures in a day, he just grinds and he tried to be very consistent, but still it's impossible to be as consistent as when you do a digital denture, because on digital denture, when you place that it's got to be 2 millimeter thickness everywhere, it's going to be 2 millimeter thickness everywhere. On a media denture, if you want it to be 1.5 millimeters thick, it's always going to come to you 1.5 millimeters thick, and so the consistency is much better. So there could be a lot of problems in a lab when you do the conventional denture. I even had just recently one doctor that had been practicing for many, many years said he never did dentures because when he was young, he tried it, denture never fit great, and he tried a digital denture because he was forced, and then he said, you know, from now on, I'm start doing it. When you choose the dentures right now, milled compared to versus the printed denture, at this time, doesn't matter what anyone will say, the milled denture will be a higher quality denture. The reason why is because when you mill the base, number one, it's milled from the PMMA acrylic. So let's talk those advantages. PMMA acrylic, it's a regular methacrylated acrylic. So when you got this digital denture, but you want to do a reline just a conventionally, you can go ahead do the reline, you can do repair, you can do anything you wanted with this denture. It's a regular acrylic denture. But the only difference, instead of injecting acrylic and it's shrinking 3 to 5%, when you mill a denture base, 0% shrinkage. That's why in a digital denture, so you don't put a palatal seal. We just put a thin line because you don't need a palatal seal. There is actually practically no space for a palatal seal. Right now, on a mill denture, we can put any type of a teeth. We can put hybrid porcelain teeth. We can mill from the composite teeth. Right now, we was able to implement the zirconia teeth into the denture. We even had some big labs came to us like Glidewell and asked how you were able, we've been trying to put zirconia teeth into the base. And I'll tell you what, there was a study that the porcelain teeth in denture destroyed the ridge, but it's not so much. I mean, when I was mentored by Dr. Johnson and he did only porcelain teeth, we did Swiss teeth from Switzerland, we would order the porcelain condylar teeth and place pretty much for every patient. And he told me, the only reason on porcelain teeth there is more deterioration in patient gum tissue, it's not because the porcelain deteriorate, it's because the denture can last so long that patients don't do the reline, don't do the replacement. That's the only problem. But otherwise, you can use a zirconia teeth for dentures. So mill denture, it's gonna be your top-of-the-line premium or signature denture that you call. The printed denture, again, we also tried many different type of materials, and right now I believe if it's printed from the Lucitan material, Lucitan printed material, this would be the best printed denture at this time. We tried practically every material that there is in the market. We tried German materials, some of the American materials, and this Lucitan right now, it's what's closest to the regular acrylic. Plus, the Lucitan right now, when they give the reline material. It's actually methacrylate material to reline their digital dentures. So you can do that right now. Another thing, the lucided printed dentures, they're much stronger than any other printed dentures. Like I said, we tried hundreds of different type of dentures from different materials, and right now the lucided printed is the best for us when it comes to printed. But still, when we do a printed denture, we consider it to be more of a basic or economy. So in your office, when you order a denture, if it's a printed denture, it's a basic or economy denture. When it's a mill denture, it's a premium denture. And in a premium denture, you can use either the PMMA 5-layer tooth, they can mill from that. They can also do from hybrid porcelain. Right now by Bego, they introduced the material for hybrid porcelain for crowns. Actually, we use them also for dentures. It is expensive material, but it's all right. To you, it doesn't cost that much more. Maybe for a lab, a little bit more. But patient can chew really well with that hybrid porcelain. Or you can use the zirconia tooth. You can order a zirconia tooth. Let's say you do over the implants. So, and then I pretty much talked about some of the advantages. I know we pretty much almost run out on time, yeah. I did hit denture over implant options. That's when I've talked about the workflow over dentures or clip-on bridges. But tomorrow I'm talking about partials. I might also talk about over dentures. But that's pretty much it. We ran out of time.
You guys have any questions for him?
Yes.
For that denture over implants option, will you be talking or discussing CDCT integration into that with markers or no?
You know, no, not. I'm not talking about do the surgical guides or anything like this. This lecture, it's more basic. It's just when you already know what's done clinically, what does lab need in order to get you a proper overdenture? And we're not talking here about more of a fixed type of a restoration, screwed in bridges, because there's many lectures, but we're gonna talk more about the clip-on and overdenture. There's a big conversion going on right now, not for every patient, but for some patients, when they get a screw retain appliance, for some reason they cannot accept. And I had some oral surgeons and periodontists called me and asked, what's the alternative? And the alternative would be pretty much a same size of appliance, but it's a clip-on. It goes into the locator, or right now there is another alternative that locator came up with. It's called the locator fixed, but you don't have to screw them. They're there permanently, but when it comes to maintain them, you have a special tool, you just place it, you snap, and it comes out. And that's another alternative, and that's what I'm gonna talk about it tomorrow. Yeah, you're welcome.
Thank you so much for presenting. You did a perfect
Thank you.
presentation. I hope
Thank
guys
you.
enjoyed it. You can share your